And welcome to Fertility Fact or Fiction, our weekly show on the web where we answer your questions live and usually have an article to review, but there were no good articles this week, so I'm just going to go straight to your questions. I am your host, Dr. Rahi Victory. I am a reproductive endocrinology and infertility specialist, board certified in Canada and in the US, and I am here to talk to you guys about all things infertility, obstetrics, gynecology, and anything else you need. Off camera is my amazing friend and helper at all times, Tariq Ibrahim from Ibrahim Strategies Group. Excuse me, and he is going to be showing us the ropes electronically while we do everything else here. So we're going to take your questions, and lots of you shared questions with us already. So we're going to go through some of those, and then if the rest of you have extra questions, feel free to jump on and ask some extra questions, and we will answer them live as best as we can.
What are the chances of an implantation from an early blast and a morula?
So morula on day 5 would be, generally speaking, fairly poor. You're not going to get a very good outcome. An early blast has a chance if it was day 5. If it's day 6, it's going to be a bit of a lower chance. There's no way to give you a percentage without knowing if your age is important and male factor is important and what your general health is like. So I can't give you a number, but there is a chance of an early blast attaching. Generally speaking, you want an expanded blast for your best chance. So an early blast is not yet expanded, but there's still a chance. It depends on when it was an early blast. A morula, assuming you are waiting day 5 or day 6, is going to have a lower chance of success. So that takes a little bit of time. Do you want me to take the question? You got them all?
Okay. I have PCOS and would like to try an inositol. What dosage should start with?
Yeah, we usually start with 1200. I just had a patient of mine ask me this because she read somewhere that you should take 2000. I haven't seen 2000. Most studies looked at 1000, 1200 in that range. So we stick with 1200 for the inositol. So that's what I would start with. Inosia, which is the main one we use, has 1200. And I think the NFH product has the same amount. So that's what we stick with.
For twins, how likely is vaginal baby A that baby B will need C-section?
I know who asked that. My morning buddy. So yeah, it actually depends a lot on how skilled the OB is and a little bit on the baby as well. So I would say in my whole career, when I've delivered twins, I've had 2 times where I had to section the second twin because I couldn't get it out or the heartbeat was not cooperating. So it's pretty rare. There are some times when it happens, but generally speaking, it's very rare. You have half an hour before there's any compromise. So from delivery of twin A to delivery of twin B, it's, you've got half an hour of time. Generally speaking, it's very easy. If the baby is upside down, meaning breech, we actually just reach all the way in and grab onto the baby's feet, and we do what's called a breech extraction. So we just pull the baby out. And I've done that so many times I've lost count, and it's pretty easy if you know what you're doing. You just have to be able to distinguish feet through the membrane, because you literally have to grab them with the sac intact, pull them down, and then break the water. So it's a little bit of a challenge if you don't know what you're doing, but if you're good at it, it's actually pretty easy. So as long as baby A is head down, we generally recommend you try vaginal, and it's very rare that I've had to do a C-section for B, so usually you're okay.
What about early compacting? Is this a bad sign?
Early compacting of the embryo? No, not necessarily. The compacting of the embryo initially is not bad. If it's compacting after the thaw, that happens sometimes. We still get success, but it's not going to be as successful as one that's continuing to expand.
Any update on wait times for surgery for ones waiting? Should we get a date soon?
So I just today was working on our application for surgery in the office. So that should be hopefully up and running in about 2 months. Outside of the office for major surgeries like open procedures, myomectomies, laparoscopic procedures, cystectomies, that kind of thing, which we can't do in the office, it's going to be months and months. They still have not told us anything about going back to normal. So we're still waiting on that. And it's becoming very frustrating for us. It's becoming frustrating for the patients. It's frustrating for our staff. I assure you, if we could do anything, we would. We literally can't do anything about this stuff. Shy of sending people to the US, I literally have no way of helping people out here. So it's a very, very frustrating occurrence right now. We genuinely don't know what to do.
When do you recommend blood thinners while stimming?
Well, certainly if you have a thrombophilia, you need to be on an anticoagulant while you're stimming. If you don't have a thrombophilia and you've never had a blood clot before, there's really no indication to be on a blood thinner while you're stimming unless your estrogen levels are super high or you have very significant risk factors for developing a blood clot, like you're immobile or if the woman is paralyzed, like paraplegic. Like limited mobility for any reason whatsoever. Obesity would be a risk factor as well. So there would be some instances, but generally speaking, it goes based on history of blood clot or a predisposition to forming blood clots. During stim, you otherwise don't need one. Embryo transfer is a different story. We do use heparin as an anti-inflammatory and a anticoagulant to help facilitate embryo implantation, and that works through a totally different mechanism. But during stim, you're really only using an anticoagulant to protect the patient from a blood clot. So the patient has to either have demonstrated they've had blood clots or they have to be at risk for blood clots, and that's mostly based on your thrombophilia status or your personal history or family history.
Is an echo recommended when you had an IVF pregnancy, and what weeks is that performed?
I'm assuming you mean a fetal echo as opposed to a maternal echo. Maternal echo, definitely no. No for fetal echo, not unless there's a predisposition to heart disease based on personal history, family history. No, we don't do fetal echocardiograms for IVF pregnancies. There is no increase in risk of fetal cardiac defects in IVF pregnancies unless there's something else going on. Maternal diabetes, on insulin before the pregnancy, paternal alcohol abuse doubles your risk of a cardiac defect. That kind of thing will definitely be important. But aside from things like there's a known history of a previous cardiac defect in an infant, or you've got some sort of hormonal or genetic problem, no, we would definitely not be doing routine echoes on IVF pregnancies.
Day 3 estrogen 310, LH13, and FSH7.
Okay.
Are these okay levels to start a frozen transfer?
Your LH level is kind of high, but the rest of it could be okay. I would need to know what your ovaries look like in terms of, are there cysts, are there eggs growing that are ahead of where they're supposed to be? The E2 is a little high for day, which is quite high for day 3. So depends on what's going on with you. Are you PCO? What's your weight? Where's the estrogen coming from? Like, we wouldn't necessarily say no to that, but I need to know the other pieces of the puzzle in order to give you an appropriate answer.
Can certain people just not mix right and keep miscarrying?
Well, that's a great question. So I get asked this frequently when we're talking about something called DQ alpha. So there are people that have what's called HLA similarities, and they share HLA types. And there is a background of belief that these HLA matches may interfere with your ability to get pregnant and stay pregnant. It is very controversial and literally probably the most confusing thing for us, because there are only 2 studies on this topic. One said it was the worst thing ever, it's never going to work. And the other one said it made absolutely no difference whatsoever. So, there are some people that are believed to have some genetic mismatching, so to speak. Does it mean you can't get pregnant? No. Does it mean it may be more difficult? Possibly. So I hate giving cryptic answers, but we don't know always. So it can be quite difficult to answer this and to give an appropriate kind of definition to this stuff because we don't genuinely know. The data is not strong enough. And I've spent quite a bit of time looking this up and found out there was even one more study that looked at other HLA types and said those were important, but the DQ one wasn't when the other studies weren't sure. So it's very confusing. Nobody knows for sure if there are genetic mismatches of patients. But generally speaking, it's rare that we can't get and keep a patient pregnant. We may need to jump through a lot of hoops. You may need a lot of testing. You may even need IVF because it does open the doors to allowing us to know that the genetics of the embryo are normal, and that's really critical to achieving success. But it's rare that we can't get someone pregnant and keep them pregnant. That's only happened to me a couple of times. And we've had lots of patients that have had multiple miscarriages. My one patient who had no significant interventions, she just actually needed heparin, which we were talking about a moment ago, I think had 26 documented miscarriages, but she ended up having several children once we got her on the right meds. So, it's all a matter of digging deep and finding out what the answers are and figuring out what's wrong and then applying the appropriate treatment for it.
Is vaginal probiotic beneficial? Who should use it? Is tablets is good or vaginal pills is good?
So according to the newest data, the microbiome of your vagina and your uterus is very important for your success with fertility and miscarriage and pregnancy and all of that stuff. So yes, probiotics are probably helpful. The problem is we don't know if administration of probiotics actually corrects vaginal, what they call dysbiosis, which is a disruption in the biome of your uterus or vagina. So we don't actually know for sure that administering the probiotics helps. So what we do is we give women antibiotics targeted at whatever antibiotics whatever bacteria are not supposed to be there. We try and eliminate those bacteria, and then we flush them out further and keep them out by kind of flooding you with probiotics to restore normal bacteria content to the uterus. So with that, we are seeing improvements in success and less losses, but it's very targeted therapy. So for example, we use PCR testing to find out which bacteria or viruses are in the uterus, and then we treat those, and then we give our patients probiotics. We do, however, use probiotics routinely with antibiotics as part of our embryo transfer program. So we're believers, and the studies support it. And I forget which YouTube video we have on it, but there is a video on our YouTube channel where we reviewed how much of an impact the vaginal microbiome has, and it's huge. Like, it's a very significant impact. So I would say yes, you should take something. Should it be oral or vaginal? In my mind, it makes more sense that it be vaginal. There are no comparative studies, so I can't tell you for sure.
If I got my first natural period after starting metformin, does that mean I definitely ovulated? I have severe PCOS.
Well, we always say that the only true test of ovulation is if you actually get pregnant, but it's possible that you ovulated. You would need to check your progesterone level to see if it's elevated. And if it was elevated, then yeah, you probably did ovulate. But that would come before, like a week before your period, where you would peak your progesterone level. So you really need to kind of look at that at the right time. So see how the next few months go. And if your period's coming regularly, you're getting PMS-like symptoms, you are probably ovulating. There's no guarantee, but you are likely ovulating. So you can check your LH levels, you can check your progesterone levels, look for an estrogen drop, that kind of thing. That'll all help indicate that ovulation has occurred. If you want to check at home, just use an LH predictor kit where you pee on the stick and it tells you. If you have severe PCOS, you may chronically have a high LH level, so they don't always work for patients with severe PCOS.
Hi, Dr. V and T.
V and T. We should just call it the V and T show.
Yeah, I'm all in. Love you both.
Oh, thank you. We love you too.
Would you recommend an immune protocol for patients with endo and adenomyosis?
So that's a great question. So I don't know that there's actually any studies out there which have evaluated immune protocols specifically for women with adeno and endo. But we do know that women with endo have elevated immune activity. And so it does actually make sense. So we do use a little bit for women that have endo. We try and suppress their endo. If that's still not working, yes, I will turn to using an immune protocol. So things like steroids, intralipids, heparin, it can help to reduce the inflammation and then, kind of achieve a better chance of success. So yes, I think that does work, and it's a very reasonable consideration. Is there data to support it? Not that I'm aware of, but I do think it's a reasonable thing to consider. That would be a great study, actually. Maybe we should look at that. Here comes my grant application. Yeah, fire away.
In the case of repeated IVF failure, no implantation, what can be treatment options or supportive medications to help pregnancy to implant?
Well, I would say that you need to figure out why it wasn't working to begin with. So is it an embryo? So we always talk about three things with implantations that don't work out. So it's either the passenger, because I like to make this as simple as possible. It's the passage or it's the destination. So passenger would be your embryo. Is it a normal embryo? Is it a healthy embryo? Is it euploid, meaning genetically normal? What's the energy efficiency of the embryo like? What's the grade of the embryo morphologically? If you look at our video from last week, we talked about whether or not your age and your morphology of your embryo are important, even when the embryo is genetically normal, and they are hugely important. So all of these things are critical for an embryo. The vast majority of the time when an implantation does not work, it's because the embryo is not normal or not good quality. The second part is the passage. Is it an easy embryo transfer? Is there blood? Is there mucus? Is your uterus upside down and retroverted, retroflex, and they can't see where they're putting it because they're still trying a transabdominal ultrasound instead of transvaginal guided embryo transfer, which is something that very few people do, but helps a lot in achieving success for those difficult uteri. So that's important as well. And then the last part is the destination, which is you. So that's a kind of huge field out there, but there are questions about your immune system and thrombophilia and infections in your uterus and the vaginal and uterine microbiome. Are your hormones okay? Is your weight okay? Is your general health okay? Do you have thyroid antibodies? Do you have hormonal problems? Are you on all the right vitamins? Do you have enough vitamin D? Is there enough iron on board? Are you doing omega-3? Are you taking inositol? Are you taking, all these different things, melatonin? Are you getting enough rest? So there are many, 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 many factors which can go into it. And so you need someone to actually diagnose that for you first. And then once they've diagnosed that for you, then you can figure out, what to do to improve it. Because just taking a bunch of supplements is not going to solve the problem if the problem is the embryo. So it's not about what medication necessarily you need to be on. It's about why is this happening? And we're really good at figuring that out. So, you can certainly reach out and we'd be happy to discuss it with you, or any RE can do that. But you need someone that's willing to listen, go through things with a fine-tooth comb, and then figure it out. So yesterday I was on the Zoom call with some folks that have had quite a hard time. They've done multiple IVF cycles at another center. And, we were going through it. And when they showed me their stim sheet, it was, in my mind, clear that there were some issues with the stim that we could have improved on, but nothing was appropriately addressed. So, it can be something as simple as, how long were you stemmed for? Was it too short? Was it too long? Did they wait one extra day? All of which can have disastrous consequences on your embryos. And in this case, it did. So I think those kinds of things need to be adjusted. And if your RE is good, he or she will pay a great deal of attention to making sure every single part of your cycle is perfect in order to get you the best success possible.
Do I need an ER if my period comes after 9 days from the old period and was heavy with pain?
Do I need an ER if my period comes?
After 9 days from the old period and was heavy with pain? Maybe RE? Maybe ER? I don't know.
I don't know what you mean by ER, but I mean, if you're talking about emergency room, definitely no, unless there's pain that's ongoing or the bleeding won't stop or something like, or you're dizzy or lightheaded. Like, I'm never going to tell anyone not to go to emerge because medical legally I can't. So if you feel unwell, please get help. But I'm not sure what that question is asking, so maybe I should leave that one alone. Yeah.
Hi, Dr. V. For patients
Hello.
who are on IVIG for immune issues during FET, what is safe to stop during pregnancy? When is it safe to stop during pregnancy?
For IVIG, most people take their IVIG before the embryo transfer and then do like 1 or 2 more treatments into it. So if you get past 12 weeks, most people are not continuing IVIG after that.
What is the miscarriage rate with the Pgta, I'm assuming?
Yeah.
Pgta normal embryo after heartbeat?
Oh God, less than 2%, maybe even less than that. It's very low. In general, if you have a heartbeat, regardless of the Pgta testing, your risk of miscarriage is generally speaking less than 2%, unless you have other factors that are predisposing you to recurrent miscarriages. But generally speaking, it's very, very low. You have a very good chance of having a live birth.
What would be your next steps if you had a patient with 2 failed natural IVF transfers with a euploid embryo, with ERA and no known fertility issues for both male and female?
Okay, so first I'd be asking why you had to do IVF if you had no known fertility issues. So if that was for sex selection, because that would be the only thing I could think of. So the biopsy process in and of itself can cause problems, which is a big part of why we don't support sex selection, aside from the fact that it's illegal in Canada. But it can be quite damaging to the embryo. So we don't recommend you do that. But again, those are cases where I hit the brakes and I go and I try and find out what's wrong. So not having any fertility issues is kind of a big catchphrase, and it may miss out on all those things I just mentioned a moment ago. So your hormones, your immune system, your blood thickening, your vitamin levels, your supplements that you're on, what's his health like? Is there any smoking, drinking, drug use? Is anybody overweight or underweight? What's your activity like? What's your mental health like? Your stress levels? All of these things can play a huge role. So there's no way to just kind of say, I would do this. I need to know what's wrong. And I very much take like kind of a detective approach to this and try and figure it out very, very carefully by dotting every I and crossing every T. Because to me, embryos are very, very precious. And I don't like just using them, over and over again without doing something that I think is positively going to impact your outcome. So we really spend a lot of time figuring out what's wrong and then addressing it in order to improve your chances. So that's a great case. Reach out to me or reach out to any RE who is willing to really listen and go through your case, with a fine-tooth comb and figure out what's wrong. Because if you failed 2 euploid embryo transfers, arguably, based on the Richard Scott study, you could just try one more time and you should overall have a 95.2% chance of a live birth. But you may also find that, it doesn't work. And I'm certainly hesitant to try that 3rd time without at least exploring what could be wrong, because that's a lot of euploid embryos and those little guys are pretty precious. So I would want to do detailed evaluation and investigation.
Yeah. Oh, we did that. Yeah. Hi, Dr. V. Just wondering, what inositol, NAC, and CoQ10 doses for women with PCOS? Thanks.
1,200 for inositol, 1,000 for NAC, and 600 for coenzyme Q10, unless you're using the Neo Q10 from Theralogics, I think it's called. So that's just one pill, which is 125, but it's like this super absorbent pill. So for all the other ones, it's 600.
Can a partner's autoimmune issues make its implantation harder or not to take place?
Depends on which partner we're talking about. So if it's a male with an autoimmune condition, not to the best of my knowledge. If it's a female with an autoimmune condition, almost certainly yes. So if it's the woman and you're trying to implant it into that woman, then yes, it can be quite difficult. Because any kind of overactivity of the immune system can very significantly negatively impact your success. And if your immune system is overactive, then you'll have it potentially attacking the embryo or interfering with the ability of the embryo to implant. And that can definitely make it more difficult to get pregnant and then also subsequently to stay pregnant. So that can most definitely be a problem.
Any updates for Windsor IVF funding?
Everybody asks that every week. Not yet. You don't need to ask. I can assure you we will be putting that everywhere when it comes out. But at the moment, no, we have not heard anything yet. I checked my email on Friday. There was nothing. Maybe this week, maybe at the start of March. I don't know yet. We haven't heard.
How successful is ProFertil for sperm viability?
I don't know if they have studies on the viability, but it would almost certainly improve things. ProFertil is actually one of the few vitamins that actually went through Health Canada approval. In fact, I think it's the only vitamin that did, to get approval by Health Canada for the purposes of improving sperm. So that means they actually presented studies which Health Canada reviewed and said, yes, this data supports the fact that this vitamin actually, or this vitamin set actually does improve sperm quality. So yeah, it works. And we do use it all the time. So it's probably very likely that it'll improve viability as well.
SCH in last pregnancy, miscarried at 8.5 weeks.
Oh, I'm sorry.
Any way to prevent it in the future?
It's really difficult to prevent an SCH. I guess I would rule out all the potential causes. So abnormal shape to your uterus, presence of a polyp or a fibroid, potentially infectious sources inside your uterus, trauma, heavy lifting, straining, any kind of smoking, drug use, especially drugs that squeeze your blood vessels, even if it's something like you took a Sudafed or you took a pill like a Sinutab or something like that, where it squeezes your blood vessels tight. So as long as all of those things are eliminated or addressed appropriately, aside from that, there is no way to avoid an SCH. No one knows what causes it in many instances, and we definitely don't even know how to fix them. It's basically just take it easy and pray that it goes away.
Does the protocol of Menopur only negative impact egg quality versus W gonorrhea? With gonorrhea?
Yeah, not to anyone's knowledge. So the original Menopur study, and the name of that study is escaping me right now, but the original Menopur study was actually a head-to-head Gonal-F to Menopur study. And aside from the fact that they had maybe a tiny bit better embryo quality, and I emphasize maybe because it was not a statistically significant outcome, there were no differences. So no, there should not be any detriment to using just Menopur. We often mix Gonal-F and Menopur because Gonal-F is really good at making lots of eggs and Menopur is really good at good quality eggs. So I love the combo because then I get lots of really good quality eggs. But if you look at this British study, which we reviewed, at the first year of the show, that was, so probably going back like 3 years. It's got to be one of our earliest YouTube videos. We reviewed a British study that looked at a lot of cycles. There was close to 100,000 cycles. And they evaluated what ratio of urinary to recombinant gave you the best chance of having a genetically normal embryo, and it was 50-50. So we use recombinant, which is gonal F, and we use urinary, which is menopure, together in large part because of that study. So that's a reasonable thing to evaluate. And that's why we go 50-50. But we don't do it for everybody. Like, it's less important if you're doing IUI. It's more important if you're doing IVF. By the way, I have to apologize for being casual. I hope you guys don't mind my attire. I'm usually in scrubs or a shirt and a tie, but I just got back from my cottage, literally got dropped off here, and here I am. So, yeah.
We have 5 embryos remaining.
Okay.
1 failed transfer. We were waiting for endo surgery to make sure it's not there. But the wait time, is it reasonable to do another transfer? But with the wait time, is it reasonable to do another transfer?
If you have 5 embryos remaining, sure. I mean, I don't have a problem doing another transfer, but I don't like unexplained failures. So if we're thinking it's endo, then there's definitely, something amiss. Arguably, if you're going to do that, it would make sense to take an endo protocol and use that prior to your embryo transfer. That does take 3 months, but yeah, I mean, I'd be willing to do that. I'd say, look, if we're suspecting endo, let's just treat you like you have endo. Lupron and letrozole for 3 months, NAC, curcumin, and coenzyme Q10. Healthy diet, make sure your estrogen levels are as low as possible for a little while. Maybe some traditional Chinese medicine. They do have some agents that work. And resveratrol, which is an up-and-coming article showing it's beneficial for endometriosis as well. So we would use that kind of approach to get you as healthy as we can and then try the embryo transfer. I wouldn't just do what I've already done, because that wouldn't make a lot of sense.
Is an AMH of 7.51 worrying for a 33-year-old? Is this level classed as DOR, DHEA helpful?
If you mean picomoles per liter, it would not be DOR, but it's probably lower than normal. Certainly lower than average. Would DHEA be helpful? Based on the studies, yes. So that's a reasonable approach to things, and we would advocate for that in your case. Yep.
Which treatment is more effective in lowering NK cells concentration activity with negative LAD, LIT or IVIG, recurrent miscarriages?
Oh, that's a very detailed and excellent question. I don't know that I've ever read a head-to-head comparison of those. I'd actually have to look that up, but I'm going to go with saying most likely the LIT, because LIT is very potent at dropping NK cell activity, but I don't know that there's a head-to-head trial. Maybe I'll look that up. I'll have to write that one down somewhere. Making notes. I'm going to look that one up for you.
I could just copy it and send it to you.
Yeah, no problem. I'll make a note. IVIG versus LIT.
What is the success rate for donor embryo transfer?
Donor embryo transfer? I mean, it depends. The success rate questions are always amazing, guys, because it depends on 1,000 things. It depends on the sperm quality, the egg quality, the embryo quality. Is it euploid? Is it not euploid? How old was everybody when they made it? What are you like? Are you young? Are you older? Are you thin? Are you heavy? Are you average? Do you have bad habits? Do you have a clean diet? Do you have a negative history? All of these things are really critical in order for us to figure out, what we can do and how we can do it.
What is the success? Yeah, read that this time. Does anti-rejection meds help with implantation for IVF frozen embryo transfer? Yes.
So tacrolimus and sirolimus are meds that work along something called the mTOR pathway, M-TOR. And I've actually been reading these. So these are a whole bunch of studies looking at how it impacts helper cell ratios, repeated implantation failures. There's a bunch of studies here to go through. So all of these have a very significant impact. It goes on and on and on. So yeah, and we reviewed that on our immune video from probably about 6-7 months ago now. On there, we talk about studies that looked at sirolimus, where it was amongst the most potent in terms of improving your IVF success rate. So yes, anti-rejection drugs can make a huge difference, according to the studies, on your implantation success. So that's something very serious. And we do use it quite a bit now with very good success rates for people that have previously failed.
I'm doing a frozen embryo transfer with letrozole
Yep.
and trigger shock.
Okay.
They want me to start vaginal progesterone on the day of transfer. Is this right? Or should it be started after trigger? Thanks.
So if you're doing it, okay, so we use it before, but then we monitor progesterone levels and we don't use the same dose. When you're using a trigger, then the issue with that is you're going to start making your own progesterone because you're using a trigger to release an egg. And assuming your egg is large enough, the corpus luteum that's left behind, which is the cyst that's left behind after your follicle releases the egg, will start producing progesterone. So if you're producing progesterone and then we give you progesterone, we can overdo it. So you need to be very, very careful. That's why those programs start the progesterone after. But even then, it should be relatively maintained unless it's starting to dwindle, in which case the pregnancy isn't doing what it's supposed to. So we actually start earlier, and we normally avoid triggering people. So we kind of do a modified natural cycle. But we do watch progesterone levels carefully so they don't like shoot through the roof, which can often be a problem.
Can you purchase sperm in Canada if you require a donor?
Yeah, absolutely. There are multiple banks, sperm banks in Canada that, not TD and Scotiabank, but sperm banks that carry samples, and you can go online and create a profile and then go through what you want and see if they have the criteria that match your wishes, and then order it and have it shipped to the fertility center of your choice. So yeah, you can buy sperm in Canada. It's been legal for ages.
Is intermittent fasting bad for IVF and FET?
So I actually looked up intermittent fasting for IVF. There's nothing. So I can't answer that because there's no data to say it's good or bad. In general, the body does not love, and pregnancies don't love, huge swings in things, and intermittent fasting does cause significant hormonal fluctuations, significant insulin fluctuations. So I'd probably avoid it around IVF. There is data on it for weight loss, and obviously it helps. I think there are some studies ongoing for PCOS, but nothing that I've seen out yet published. I looked about a month ago, so I don't know if something's come out since, but a month ago there was nothing yet.
You're not supposed to fast when you're pregnant.
No, during pregnancy, I don't think any religion expects you to fast. Although I have had women from various faiths, not to pick on anybody, who wanted to fast while they were pregnant, and I had to tell them no.
There you go.
Yeah.
What are the chances of an embryo splitting? What about transferring 2 embryos and both splitting?
Yeah. So the chance is 1 in 300. So it's very rare. There are some factors which can contribute, like assisted hatching, that increases the risk, which most of us do. I would happily say I've never seen it before, except it happened to us about 3 months ago when we transferred 2, which I do very reluctantly these days. It's rare for us to transfer 2. Generally speaking, almost always we're transferring 1. And sure enough, they both split, so she had quads. Thank God one self-discontinued. So there's triplets. So yeah, it's very complicated to have quads. Every physician will recommend you reduce. So and the guys that reduce are becoming, the guys and girls, I mean that generically, guys, are actually becoming more hesitant to reduce because they're realizing now that there's a fairly high preponderance of loss or complications in the pregnancy from having a significant volume of basically dead tissue in with the live babies, and it gets infected, and then it can cause the other babies to come very early. And we've experienced that once in our program here. So yeah, it can be very, very complicated.
Is IVIG similar to SCIG?
For all intents and purposes, yes. IVIG is just intravenous immunoglobulin, and SCIG is subcutaneous, so it goes into your fat. They're basically the same. There are no head-to-head trials yet, although I think someone will have to do one soon. The big difference is that sub-Q is basically free here, and IV is like $5,000 per treatment. It's insane. So we don't ever do IVIG. It's just irrational to do that. It's so expensive. I've done it once for a foreign patient that insisted on it. So we tried.
How normal is it for the fraternal twin to bring growing and measuring at a different rate at 10 weeks? One is measuring 4 days behind.
Oh, 4 days behind is nothing. That's within the realm of inaccuracy on ultrasound. So that's not even something to think about. Ignore that completely. It's nothing.
What is the general process for a surrogate if one is able to transfer their own embryo? Are there additional expenses?
There are, because we have to screen the surrogate. We have to talk to them. We have to go through everything with them. There's enormous amounts of testing that are required, teaching, preparation, all of that stuff. So there's a little bit of a cost associated with it, but it just requires we identify a surrogate, whether it's someone you know or someone you find through an agency and get to know. Either way, you have to get to know them. And then basically beyond that, it's just a matter of making sure they're right. So that's a lot of questions, a lot of history, a lot of my, going through things with them to make sure they're good surrogates. And then as long as everything's okay, we then test them to make sure that they're perfect. And if they've passed the screening, they've passed the testing, they're ready to go. And then it's just a matter of having a legal contract, and we can do whatever you want, whenever you want.
Does taking aspirin help with implantation?
So there are no studies that show that taking aspirin improves implantation, but I'm a believer. Many fertility specialists are, some are not. There are reduced complications in pregnancy, including preeclampsia and preterm labor. So I use it. And there is a study that shows that it may help with implantation, but it's really controversial. We have a pretty big video on aspirin and IVF on our YouTube channel too. So check that out. Just go to www.youtube.com/drvictory for Dr. Victory. Click that subscribe button and make sure you comment and give us a thumbs up if you like the video.
I have a high mosaic. Should I transfer it?
The recommendations are that you not do that if you can produce additional embryos. If, in other words, do another IVF cycle. If you cannot afford to do another IVF cycle, or you don't want to do another IVF cycle for any reason, you need genetic counseling before you transfer a high-level mosaic. And keep in mind that the likelihood that it'll work is reduced. It's very low, in fact. So we don't normally recommend that.
Everywhere.
Is it a busy night?
It's sporadic. Cannot thank you enough for doing these shows.
No, great.
You got me through IVF, and now I have a 3-month baby.
Oh, fantastic. Thank you for sharing that. That's awesome.
I did 60 days of Zoladex before my last transfer.
Yep.
Should I do it before the next transfer?
Yes. If that was before the one that was successful, meaning this is a whole new cycle and it's been like a year or something, yes. If it worked for you before, definitely do it again. Yeah. Now, if you're breastfeeding right up until the point you're about to start your next IVF cycle, it probably won't make much of a difference, because breastfeeding with the high prolactin levels suppresses your estrogen, which is what you're using the Zoladex for. So it'll probably have the same result and impact. And so you don't necessarily need to do it for that. You know, I realized the other day watching one of my own videos that I move my eyebrows way too much when I talk.
A lot of things going on here, man. Don't worry.
There's a lot of facial
There's a lot of things
expression
going on here.
Yeah, I gotta like keep my eyebrows level the whole time.
No.
Yeah, go ahead.
What is the general process for a surrogate if one isn't able to transfer their own embryos? Are there additional? Oh, we did that.
Yeah, I think we did that one. Yeah.
Okay. Hi.
Hello.
I've asked this a couple times.
Okay.
For patients on IVIG due to immune issues during FET, what do you typically stop the treatment during pregnancy?
We did that one. Yeah. So we've answered that. So go back and watch in the show. But usually most people are stopping around 12 weeks. So we stop around 12 weeks.
IVNT.
VNT. You got a love today too. That was good.
Every day I got a smile like this. It keeps me for the whole week, man. I get more love here than anywhere else. My partner and I are going for the second retrieval.
Okay.
On our holiday, he smoked a pack of cigarettes.
Oh.
Should I postpone the retrieval for a month? Does it make a difference?
A month won't, because anything he did will have an impact for up to 3 months. If it was one pack of cigarettes over holidays, I mean, I'm very anti-smoking, so I would hold off. But I mean, it depends on the other factors involved in your care and your case. So yeah, smoking, never good. It's terrible for fertility. It's a huge reduction in success. So we don't let any of our patients smoke. So take my bias in mind when you make your decision, but I am vehemently anti-smoking, so I'd avoid it if you could.
If you are triple vaccinated,
yep,
how long does it stay in your breast milk for? P.S. I miss you guys.
If you're triple vaccinated, how long does it stay in your breast milk for? I don't know if they've done a duration study yet, but probably 3 to 6 months, like the antibodies do in general in your body. So it shouldn't be any different in your breast milk. And we miss you too. Who was that?
It's an Instagram name, Ivana Lamantia.
Oh, hi, Ivana. We love you. How's the baby?
Do you have advice for keeping hope after multiple failed FETs?
So mental health during fertility treatment is huge. So we are very proud of the fact that we have like one of the best programs out there. So we have an online program, we have a social worker, we have our naturopath, we have a psychologist. We've even got an addiction specialist for people that have addiction. We recommend acupuncture. We recommend stress reduction. We have a family doc that does counseling for people that can't afford the counseling from social worker or the psychologist. So there's all sorts of opportunities for you with us. So that's really important. To be honest, I think what patients need to hear is that there is hope. And in order to figure out if there is hope, you need an RE that's A, listening to you, and B, figuring out what's wrong. So you can't just kind of go through the same thing over and over again and expect the patients to feel that they're going to be hopeful. You got to offer them something in order to give them hope. So we have loads of patients, like I said earlier, that go to other places and then they ask us for a second opinion. And when I kind of comb through their study, I'll find that there's actually something wrong, or something that was missed, or something we could do that wasn't missed, but just, hadn't been done before. And sometimes it's simple. It's like supplements. Sometimes it's complicated. Sometimes it's adjusting how you stim, or how long you stim, or what your dosages are, or whether they used ICSI or they didn't use ICSI, and all sorts of different things. So we're very keen to help people. And I will very rarely take someone's hope away. But at the same time, I am very realistic. So, I mean, I had a patient the other day who was in their more advanced reproductive years. who very clearly I could tell was not understanding that their chances of success were going to be extraordinarily low just because of their particular set of circumstances, in addition to age. There were other factors. And, I tried to explain that the chances were low, but I could just tell that they were thinking that it wasn't going to be low because something amazing was going to happen for them. So, I mean, that's not realistic. So you have to be honest with patients, but no physician should ever rob a patient of hope. There's always choices and options. And within a reasonably ethical framework, there are always options to try. Now, if someone 50 shows up and wants to do IVF, I'm going to tell them, look, your chances are negligible, and that it would be extraordinarily rare for this to work out using your own eggs and your own uterus and all that stuff. And here are all the risks, including physical and emotional and financial and so on and so forth. And if that individual, after talking to me and probably talking to our psychologist and going through the nursing and everything, still wants to try because they need that closure, I will still do my very best to talk them out of it. But I feel like people deserve to make their own decisions. Would I do it multiple times? No. I would say in advance, we need to have a line drawn in the sand so that, you can say you tried once and we're done, or you tried twice and we're done, or whatever that number is for that patient. But am I going to do it over and over again until it works? Absolutely not, because that's just unethical. And IVF, I've said this before, I'll say it again, it can be really addictive, where people think like if they just keep trying, it'll work eventually. It doesn't work like that all the time. And sometimes your chances are so low, I have to kind of be the guide to help you see that, the path we're on is not going to lead to where you're, wanting to go. You want to go there, and we're on a path going this way, and it's not going to work to get us to there. So yeah, we're very careful about that, but there's always hope. In most cases, it just depends on what you want to do. And we have loads of resources to keep that hope, from me to our nursing team to all of our staff, and then our affiliated mental health program. So let us know if we can help you, we will.
So regarding a saline infusion sonohystogram.
Oh yeah, that video is up to 37,000 now. Yeah, that video is a machine. It is good. Yeah.
Is the dye the same everywhere? Is there one safer than another? I heard someone said iodine, and then I hear saline. Thank you. And who should perform the test, doctor or tech?
So it can be done by a doctor or a nurse, a really well-trained tech, or a tech that has medical training, that kind of thing. There are various options depending on where you're working and which country and so on. So in terms of your saline, so if it's a saline infusion sonohystogram, definitely never iodine. I think you mean radio opaque dye if you're getting a hysterosalpingogram. But when you're doing a saline infusion sonohystogram, you never want to put iodine in the uterus. That would be a disaster. So you're using either saline or Ringer's lactate, which is kind of like saline, or a special fluid that actually will help you see the tubes better. So there's one called XM foam. There was another one that used to be around before, which I can't remember the name of now, but all of these products are available that help you to see the fluid when it's going through the tubes. But not iodine, definitely not iodine. And none of the products are better than each other. They're all the same. They do help you see better than the saline, but they don't help you see better than one another. They're all the same.
Now that you mentioned the eyebrows, it's very obvious. This is eyebrows a lot. You brought it on yourself, man.
I brought it on myself. I do. I have a very expressive set of fuzzy eyebrows.
What are the chances of successful sperm extraction if you have non-obstructive Azuspermia?
If it's non-obstructive and the testicles are working, and it's done properly, the chance should be extremely high. If it's non-obstructive azuspermia because the testicle is in failure, the chances are negligible. So it all depends on what the problem is. I know talking to the urologist, and depending on which one you speak to, extraction procedures are anywhere from like a low of 10% up to a high of about 50%. So it depends on what you're dealing with to tell you what the success rates are.
Can you exercise throughout an IVF cycle, or is that too much stress for the process?
Light exercise, yes. Heavy exercise, definitely no. And there's torsion risks if you're bouncing around or jumping up and down and that kind of thing. So you do have to be quite careful. So light exercise is good, but keep in mind, in an IVF process, we're focused on getting as much blood and oxygen and nutrients delivered to your ovaries and probably eventually your uterus. And when you're exercising, you're redirecting that blood flow to your muscles. So you don't want to necessarily direct too much blood and oxygen and sugar away from your ovaries, because that's where we really want it targeted. So don't overdo it. Light exercise, sure, a walk, a light treadmill, an elliptical, some light weights, some yoga, that kind of thing, sure, but don't be doing hot yoga while you're trying to do IVF. I mean, that's not healthy.
Have you started in-person consultation, or is it still over the phone?
So actually, with the exception of a very brief period of time, we never stopped in-person consultation. If you want an in-person consultation, just ask for an in-person consultation. We still do them. It's just that most people like the convenience of not having to come in. And so for better or worse, COVID has changed everything, because I spend most of my day in my office with either Zoom or my trusty headset on. And I'm doing all my consults via phone or Zoom. So that's the majority of what we do. But if you want to see me in person, by all means, I'm happy to see people in person. It's kind of nice to see people in person. So come on out. I'm happy to chat with you.
Is it an easy process if a woman decides to have
That's
a
the
child
surrogate.
with a sperm donor or single one with no fertility issues?
Oh, is it? Or is that a new one?
It just popped up now.
What was it?
Is it an easy process if a woman decides to have a child with a sperm donor as a single mom with no known fertility issues?
It's a simple process. Is it successful all the time? Not all the time, but it's a very simple process. You just have to come in and we check you out and make sure you're okay. And if your fertility is normal, you choose sperm, you have it shipped here, and we inseminate. And we would, depending on your age, recommend somewhere between 3 to 6 tries. And usually the success rates are pretty good with donor sperm. I thought that one sounded like the surrogate one.
There's a lot of
repeats.
Sounding alike. I get caught all the time. Do you have advice for someone with Robertsonian translocation 1314? How many IVF cycles with Pgta testing should one plan for? Could you have more success with IVF or naturally at a younger age?
Well, you're definitely going to have more success with IVF because you're going to get something called Pgta-SR, which stands for pre-implantation genetic testing for a structural rearrangement. And we're going to know if your embryo is normal or not, and we're only going to use the ones that are normal. So yes, your success rates will be better with IVF, and you should strongly consider doing that because it'll drastically reduce your chances of having a miscarriage or of having a complication in the pregnancy with the baby, or the baby having it. So yeah, IVF would be a great option. It's fairly straightforward to do. How many cycles? That depends entirely on how many eggs you can produce. So if you can produce a lot of eggs, we've had success with just one cycle. If you can't produce a lot of eggs, then you may need multiple cycles. It depends on how many.
Hi, Dr. V. and Tarek.
Hello.
I will be having a fibroid removal, tubal ligation, and endo excision.
Oh, wow.
How long would I have to wait until I can do an FET?
Minimum 3 months if you're having a fibroid excision. That's if it's in the wall and they're actually cutting you open to remove it. If it's just inside the uterus and it's being done hysteroscopically, like a month or 2 for everything to heal, and then you're good to go. Are we done? Did we nail it right at 9 o'clock
It
for
looks
once?
like I'm skimming through. I see.
Were there Instagram questions that we missed?
There could be. There could be a lot of those.
Oh, there's a ton.
Which one would be better choice, IUI or IVF? Last question, I guess.
Which one has better what?
Which one would be better choice, IUI or IVF? Just like that.
Well, that's a loaded question, right? So it depends on you and what you want and who you are and what you've tried and what your diagnosis is. IVF, as a general rule, is always going to give you a higher chance of success, but it's not necessarily the thing you go to for every patient, and we definitely don't push it. So many patients would benefit from just trying IUI first. Some patients actually are wasting their time trying IUI first. So it's all up to the patient. Yeah.
And then, does coenzyme 10 really increase egg quality?
Oh, I know who that's from. Hi. Yes, it does improve egg quality. You have to use it for a long time, but it does improve egg quality. So definitely use that.
Hubby's sperm count is very inconsistent. Any insight to why or what we can do?
Personal habits, obesity, lack of exercise, lack of ejaculation, lack of vitamins, excessive heat, chronic sitting. All of those things are factors.
Hello, doctor. I have MTHFR 677TT homozygotes.
Oh.
Should I take extra folate in add to 400 mcg folate?
You need folinic acid instead of folate. So you need folinic acid and you need aspirin and heparin, both. And we are at a conclusion of the show. Well, it is now 9:01. Thank you for joining us on Fertility Fact or Fiction. And we always love having you guys here. Amazing series of questions tonight. I'm going to have to look up IVIG versus LIT and get back to you guys. And always make sure you watch the show because we do answer your questions. You don't have to ask on multiple platforms. We will get to it, but I can't promise I'm going to get to it at the start because, as you can see, we have like 100 questions at every show. So hang in there and your questions generally will get answered. If for any reason they didn't get answered, just contact info@drvictory.com, set up a consult, and we'll be happy to answer in person. I hope you guys have a great week and stay well. We'll see you again next week on